Hi everyone. Today we will discuss about breast pathologies. To discuss the breast pathologies, we need to know the normal components of the breast and the normal structures from which the breast tissue is composed of. So, if we talk about the normal composition of the breast, we know it is made of ducts, stroma, the stroma composed of blood vessels, sporting tissues, capillaries, and fat, and the glandular elements. So, these are the three basic building blocks of the breast tissue. Number one, ducts, number two, stroma, and number three, glandular tissue. So, all the pathologies of the breast are derived from these three basic elements. So, we will discuss these pathologies which are derived from these elements one by one. Today, we will discuss about only those pathologies which are derived from the ducts. To understand the duct pathologies, we need to understand how ducts are distributed in the breast parenchyma. So, if we start from the nipple, there are many orifices of the ducts which open into the nipple, and these orifices are arranged in the nipple in two fashions: the central orifices and the peripheral orifices. These orifices are actually the continuation of the ducts. So, if we start from the orifices, these orifices develop into segmental ducts, then further they form subsegmental ducts, then the terminal ducts, and ultimately ended in blind ended units called acini of the breast. So, this is the basic structure of the ducts starting from the nipple to the alveoli and the acini. These acini and alveoli are internally lined by epithelial tissue, and outside the epithelial tissue there are myoepithelial tissue. Myoepithelial tissue are basically the muscle tissue which propel the milk which is produced inside the acini towards the nipple. So till now we have understood the basic architecture of the ducts from the nipple to the acini and how ducts are composed of. Internally there is epithelium, and outside the epithelium there is myoepithelial tissue. So these pathologies which are derived from the ducts are basically either in the terminal ducts, either in the segmental and subsegmental ducts, or in the orifices or lactiferous sinuses. So it's important to understand here that all this duct architecture of the breast is lined by the basement membrane, an uninterrupted basement membrane. So this uninterrupted basement membrane is very important, and when this basement membrane continuity is disturbed or disrupted, then it means that there is some pathology which is disturbing this normal continuity of the basement membrane. So let's discuss which possible pathologies, either benign or malignant, can be derived from these duct structures. So if we talk about the benign pathologies, these benign pathologies can be inflammatory, like inflammation of the epithelial or myoepithelial components of the ducts. There can be benign duct ectasia. There can be periductal mastitis, which is simply inflammation of the ducts. There is apocrine metaplasia and intraductal papillomas and papillomatosis. So these are the benign pathologies. So further, if we discuss about malignant pathologies, this can be ductal carcinoma in situ. It can be invasive ductal carcinoma. Now, how ductal carcinoma in situ converts into invasive ductal carcinoma, the basement membrane decides this differentiation. If the basement membrane is disturbed or lost, then it is invasive ductal carcinoma. If the basement membrane is intact, then it is ductal carcinoma in situ, and the Paget disease. So these are the possible pathologies which can be derived from the ducts. So now our objective is to understand how these pathologies appear on imaging, on ultrasound, on mammography, on ductography, how these pathologies appear, and how we can differentiate these pathologies from other breast pathologies. So now we discuss what imaging modalities are used to image these pathologies of the ducts. The most conventional method, which are we using since ages, is the ductography or galactography. The technique of ductography is very simple. We place a cannula into the breast nipple and then inject the iodinated contrast agent and take the images. These images are usually obtained on two views: mediolateral oblique view and craniocaudal view, but mediolateral oblique view is more commonly used. If the ducts are normal, this contrast appears to opacify the ducts smoothly, and these ducts end into fine tapering ends. So if this pattern appears on the mammography screen, then it means the ducts are normal. If there is any interruption into the ducts, into this smooth flow of the contrast, then it means there is some pathology which is obstructing the contrast agent freely smoothing and freely and smoothly flowing into the ducts. If there is interrupted dilatation, then normal duct, then dilatation, then normal caliber, it means the duct is not normal. The duct should be smooth and it should taper smoothly when goes distally. If there is any interruption inside the ducts, this normal appearance is disturbed and we can assess it on ductography or galactography. But now in modern practice, the ductography or galactography has become obsolete or is becoming obsolete or near to become obsolete. High resolution ultrasound gives us a very clear picture of the ducts, especially retroareolar ducts. If there is a tissue inside the ducts or there is duct ectasia, it is fairly and excellently picked up on the breast ultrasound. So, if there is a suspicion on ultrasound, then breast MRI is advised. In breast MRI, the most important sequence is T1 weighted pre-contrast and post-contrast sequence, and sagittal views are the most important one. In T1 weighted pre-contrast images, the normal ducts appears hyper-intense structures due to containment of proteinaceous milk or blood within the ducts. So if there is milk within the ducts which is normally present, or there is blood within the ducts, they appear as hyperintense structures on T1 weighted pre-contrast images. So now why post-contrast images are needed? The post-contrast images are needed to know whether there is enhancement of the duct walls or not. If there is enhancement of the duct walls, we already discussed that duct walls are made up of epithelium inside and myoepithelial tissue outer to the epithelium. So if there is enhancement of the duct walls, it means that there is increase in blood flow of the duct epithelium and myoepithelium, and this increase in duct flow can be in inflammatory conditions if it is diffuse, or if it is focal, it can be malignant like invasive carcinoma, ductal carcinoma, or ductal carcinoma in situ. So far we have understood that which imaging pathologies can be discussed on mammography, on MRI and ultrasound, and how normal ducts appear on ductography, ultrasound and MRI. So in next lecture we will learn how these ductal pathologies mimic with other breast pathologies and how we can differentiate between ductal pathologies and the other breast pathologies, and where are gray areas where there is differentiation is difficult, and we need to perform a histopathological analysis by doing image guided breast biopsy. Thank you.